The interpreters, I think, let me just quickly check if they are on mode. I don't think so. If you don't mind just sending the message to the interpreters and then just sending me a WhatsApp. And then let me share screen and then we can get going. Nkechi, are you ready to continue? I will try to manage the conversation in the absence of Dr. Abdullah.
Okay, yes, good.
Thank you all, very welcome. I do apologize for the disruption, but we're back, and yes, it's the first time for everything. Thanks, Peter. We're over to Dr. Nkechi Olalere from Spark, who's talking about Spark and the issues. Nkechi, you can continue. We'll try and make up how we proceed. Thank you for sticking in there.
Great. So thank you so much, and thanks everyone for your patience. Indeed, experience.
Merci à tout le monde et
awesome.
Je vous remercie pour votre patience.
So,
Alors,
I will start again by talking about Spark.
Je veux commencer de nouveau
Spark
par
is Strategic Purchasing Africa
pour
Resource
parler de
Center,
Spark.
And we are really focused on supporting countries to make the best use of limited
Nous
resources
sommes
and
tous,
their journey
nous
towards
fournissons
universal
de
health
support pour
coverage.
tous les pays de l'Afrique en ce qui concerne les soins primaires.
So we have our technical approach, which is really about
La couverture
strategic
sanitaire
purchasing,
universelle.
but then we're also equally as much about how we do it. For us at Spark, we always put the country in the driver's seat, ensuring that support to them are provided by people who understand their context, people who understand how this work should be done. They have relatable experience. They probably worked in that country, are from that country, or from somewhere that is neighboring, and are able to provide context-specific supports to countries. And so in doing this, we have now been able to really create this critical movement, this regional cadre of experts who serve as our go-to source of strategic purchasing, not just for Spark, but for other institutions and countries that are undertaking different aspects of strategic purchasing reforms. And then we match these experts to specific countries, different countries undertaking different strategic purchasing reforms. And then finally, we ensure that all of the learnings, all of the lessons from these country engagements, that we are able to share them, facilitating cross-country learning and also producing knowledge products, tools that are useful for countries as they also navigate this sort of change or this sort of process in their different countries. Next slide, please. And so having spoken about Spark, the next question really is, what is the big deal about primary healthcare? Why are we so fixated on it? What is the link between strategic purchasing and primary healthcare? Well, I will quote WHO that asserts that a strategic purchaser prioritizes primary healthcare and does everything in his or her power to protect funding for those services. I'll take a pause just to talk about what we found in the height, at the very height of COVID-19, when the pandemic really started. We found out that a lot of essential services, a lot of primary healthcare services were sort of falling through the cracks as countries try to mount an appropriate response to the pandemic. This raised a specific concern because it kind of meant that potentially we might be going back, losing some of the progress that we had actually made, whether in terms of eliminating vaccine preventable diseases, or even just the numbers that are attending health facilities for routine maternity care and all of that. So this for us was particularly concerning Also, because we understand that primary healthcare is the programmatic engine for universal health coverage. And as WHO says, this is in all contexts, in almost all, if not all contexts. And why is this? It's because primary healthcare really focuses on the community, providing the care that the community needs at the point where they need it. It's really about the right priorities, and it helps to really get us on that journey towards universal health coverage. And to date, it still remains the most cost-effective way of addressing comprehensive healthcare needs close to the communities that we all serve. Next slide, please. And so for us to really, so we've made the point that primary healthcare is critical to achieve universal health coverage. I guess the next question then becomes, how do we move from rhetoric to real action in ensuring that primary healthcare really becomes the cornerstone for our programs and to achieve universal health coverage? It's going to take quite a bit. It's going to take investments, but we can also see the results that can come out from it. But the question then becomes, are we ready to make the investments? We always talk about the fact that universal health coverage is a political choice. And so when we see the investments that need to be made, are we all committed to making that? And I'll just go through some of those investments. To achieve the targets for primary healthcare, we require an additional investment of around $200 billion per year. And then to achieve universal health coverage, we require an additional $170 billion per year. And even though these numbers look very big, they actually represent only an additional 5% increase beyond what is already being spent on health globally every year. Having said that, whether it's 5% or 1%, it's an additional burden on countries that are already struggling, especially in LMICs, to meet the needs of the health sector and other sectors at this time. And so the question then becomes, if we spend this, what are we getting? And what we know that we can get is that if we scale up primary health care, we could actually save 60 million lives and increase average life expectancy by 3.7 years. If we invest in broader health systems, which will be part of this work of increasing access to primary health care and investing in that, then we could save close to 100 million lives. So I think the case is compelling. But then for us to then be able to raise that money that is needed, we need to do some things ourselves in our countries. And I believe that that's where this conversation for today really anchors how we are funding primary healthcare in our different countries. And so the options open to us are, of course, domestic revenue mobilization, just digging deeper and trying to understand how we can internally generate more funding without depending on donors. Will that be more budget allocation? How many countries have actually met the 15% of budget declaration targets? Will that be tax financing, which is also a conversation that is really on the front burner these days? Or will that be looking at more innovative means of generating revenue, especially domestically? Will that be talking about whether it's debt swaps or having philanthropic donations? Or will that be social impact bonds? There are so many different innovative financing mechanisms that are available. Which one of these are countries leveraging to increase their domestic revenue mobilization? Or will that be a focus on purchasing more strategically, specifically focusing on allocative efficiency, really allocating funds to where we know that they can do the most good, in this instance, speaking to primary healthcare. So these are options open to us as different countries on our journey towards universal health coverage to really move from rhetoric to real action. And then the next slide, please. And so just to kickstart the conversation that we're going to have, I'm going to share some examples of how countries are improving the delivery of primary health care, funding the delivery of primary health care, and increasing access to primary health care. One of the countries captured here, Rwanda, also has a presentation that will really take you deep into how the country is prioritizing and increasing funding for primary health care. But I just give a snapshot of some countries in Africa and what they're doing to actually fund primary healthcare. So the first here is Burkina Faso, and Burkina Faso utilizes tax finance subsidies to cover user fees for primary healthcare and for hospital care for priority population in public health facilities and some accredited private health facilities. In Nigeria, the National Health Insurance Scheme and the state health insurance schemes pay providers using capitation for primary care. And the focus on capitation is really because capitation focuses on health promotion, on preventive health services, ensuring that people access care close to them and that there's a referral system that moves them up. So that's how Nigeria is also ensuring that primary healthcare is on the front burner. In Uganda, there are now primary healthcare grants with specific allocation formulas based to health facilities based on their catchment areas. Again, this puts the power in the hands of the provider, ensuring that there is sufficient funds flow to the front line where they're needed to actually provide the right care. In Kenya, we have the Ministry of Health and the County Departments of Health that are testing new primary healthcare networks as contracting units, in which the county hospital acts as the clinical and administrative hub for a geographically defined set of primary care providers, regardless of the ownership type. So this is really like a hub and spoke approach, ensuring that all of the different primary healthcare facilities have support at the center. And finally, I'm just going to briefly talk about Rwanda, but Stella has a great presentation on how Rwanda is funding primary health care. But Rwanda has a very interesting pyramid-shaped health system where you have a lot of community health workers, health centers, and health posts at the bottom of the pyramid, providing care for the communities, ensuring that everyone has access to great care. Now, this pyramid structure is really supported by a mandate by the Ministry of Health that speaks to the fact that there has to be a health post in every cell that does not have a health center. And the big idea here is to ensure that people do not have to walk for more than 1 hour or more than 5 kilometers to be able to access healthcare. And they've been able to do this in a very creative partnership with the community. It's a partnership called the Public-Private Community Partnership to bring this to pass. And then there is also a plan for capitation, again, just to increase funds flow to primary health care, especially for the last mile, as we call them. So these are some of the things that we are seeing in the work that we're doing in different countries at Spark, and why for us it's really very critical, why it's very important for us to focus on primary health care. And with that said, I hand it back to Shabir to then introduce the great panelists that are going to take us deeper into what they're doing in their own countries to do this. Thanks again for this opportunity to present to all of you.
Well, thank you very much. I think Almugira is here.
Yeah,
so
yes.
Go ahead.
Thank you very much, Dr. Ketchi, for this very nice presentation and for informative things. And I think we have... And I think we have some messages from your presentation that PHC is really crucial to the achievement of universal health coverage, and efficient use of limited resources necessitates the investment in primary health care in terms of allocative efficiency. And the last message I think is that although we are still away from our destinations, in African countries, but nevertheless, there are successful stories in many countries in Africa, and that needs to be marketed to other countries and reflected to them. Thank you again for your presentation, and I think now we are going to introduce our panelist, Dr. Anna. Anna Feni is a senior research fellow with the Institute of Statistical, Social and Economic Research at the University of Ghana. She has researched and published in the area of developmental issues in institutional and health economics. Her current research areas include health financing, health seeking behavior, integration of governmental policies into service delivery system in Africa, social protection, and gender-based analysis. Also would like to welcome Stella, Stella Ambuza. Yeah, she is a lecturer and researcher in the University of Rwanda, School of Public Health, the Department of Health Policy. economics and management. She has over 10 years of experience working in public health system. Currently, she serves as a member of the community-based health insurance consultative group and health financing core group in Rwanda. Stella recently developed Rwanda's health financing strategic plan. That is great, for 2018-2020, and the family planning investment case. Over the years, she has provided technical assistance to various government institutions and international organizations in developing policy documents and briefing notes to inform decision making. You are all welcome together with Professor Shabir. And Professor Shabir, as you all know, he's a professor and academic member also in the University of Wits in South Africa. He's a coordinator, executive coordinator of AfroPHC. Actually, he's a founder of many African hubs for primary healthcare, academic, and he works in many areas that is very difficult for me to encounter now. You are very welcome, Professor Shabir, in moderating the discussion of the next session together with Anna and Stella.
Thank you very much, Dr. Abdullah, and appreciate the comments that have been provided by Nkechi on the question of primary health care and how Spark is actually taking that forward. I'm going to leave the slide up because in some ways I just want to share with the audience and perhaps the panelists and Nkechi as well. Some of the sort of thinking where AfroPHC has been and where this discussion of primary healthcare funding popped up in discussing priorities around strengthening primary health care and the primary health care team in Africa. Key question came up. We need more funding. We need more money. And, that's as much as any provider on the front line tends to think. I look around and I see dysfunction, but problem is we need more money. I know there are issues about how systems work. And we've realized that, yes, we need to actually look at strongly decentralized systems with managers that are capacitated to manage. And, there are many managers who, if the resources were in their hand, would do a great job and as close to providers as possible. As part of the team of providers, we'd get some very good results. At the moment, and we'd want that funding, that money to be in their hands in a meaningful manner, of course, not wanting corruption, etc. The other thing is that our notion of how money comes down is we think of, well, you know what, there's a budget, somehow government gives it to, these different departments. And in some places where we don't see the money in the facility, it's somehow locked somewhere higher, in a province or a region or somewhere that's not close to the facility and the managers and the providers locally. So we see that budget and it's kind of held back. But we know that strategic purchasing is actually trying to find ways in which that money is not locked up at a high level, but finds its way right down to the provider, which we like, and there are different ways in which those can be. It could be in the private sector where there's fee for service, but we know that can be a lot of overutilization and cost overruns, which are really challenging. And, it is challenging to work with that. It's not very friendly to primary care, because we don't know how do we bill for health promotion or sitting down with a social worker or getting a community health worker to follow up or an extended consultation around a family problem. So these are, fee for service is not the best way. Capitation, on the other hand, we kind of familiar with it, but it doesn't sound very, it sounds very odd, not unknown. And that's actually where lots of people are going, but there are other ways. So our notion at the moment is that, it would be for AfroPHC and providers on the front line much more beneficial if we have capitated systems which are mixed with some fee for service and performance management. And that is kind of the thinking at the moment. So perhaps with just that sort of sense of where AfroPHC is sitting in this discourse, having this discussion is about us, in fact, trying to see if we as AfroPHC can articulate better and understand better, and then articulate better a position that is very synchronous with with the ideas that come from Spark and the network of people high up in governments all over Africa, like has been spelt out by Nkechi. So we have this idea of teams and being population defined, and we'd like to figure it out. We know that if we are going to be much more effective, efficient, we will be doing better. But there are ways in which we can be. So let me stop there to say that's kind of food for thought. We're going to ask that question in group discussion. But before we get into that group discussion, as how do we as frontline healthcare workers talking to people who are actually high up in the in the echelons of government, what do we think is going to be the best way to move forward will be the discussion. So before we get there, let me hand over to a question, and Stella is going to do a presentation. And I think the question is, share with us, some country experiences on the development of primary health care and the funding system, payment system. So over to you, Stella. Dr. Umoza is from Rwanda, and we really appreciate her sparing some time. I know she's under pressure for time, but go for it, and I'll do next. Move to the next slide if you want. Stella, if you are able to unmute yourself, otherwise just let me know by chat if you're okay. Stella left us. Oh, hang on. Stella, I'm giving you the option to unmute yourself.
Thank you very much, Shabi, for this opportunity to present and talk about primary healthcare system in Rwanda. As you mentioned, it's I work for the University of Rwanda School of Public Health, and it's an honor to have me so that I can give you a briefly how the primary healthcare system is financed, how it works, and the lesson learned over time. My presentation will focus on, I'll give a little bit of introduction, and I'll talk about the organization of the primary healthcare system in Rwanda, and explain who are the key primary healthcare providers. And I also focus on the roles of community health workers, how they work, how they are paid in Rwanda. I also talk about the provider payment methods at the primary healthcare. And also I will conclude by sharing with you some of the key challenges we are facing, and also the lesson learned over the last 2 decades in Rwanda. Next. First of all, the healthcare sector in Rwanda has a clear vision and a clear mission that guides all the activities or intervention implemented in the country. The vision is to improve the health of the population of Rwanda through a very coordinated system where all stakeholders from all the levels has to contribute to ensure that the lives of the people are catered for, and also stakeholders should also contribute to poverty reduction. And the mission of the health sector is to continually improve accessibility of preventive, curative, and rehabilitative services, ensure the quality, and also enhancing the general well-being of the population. Next. And this policy orientation has also clear objectives. The objectives are to ensure universal accessibility in terms of geographical accessibility and financial accessibility, and make sure that the healthcare services are equitable and also are affordable for all the Rwandans, including the poor and the most vulnerable population. And these policy objectives also guide the general objectives when it comes to the implementation of healthcare programs, whether maternal child health program, whether communicable disease or non-communicable diseases. All these policy orientation, mission, guides, and also gives a clear definition of policy and also of key intervention to be implemented in the country to ensure that the program are able to deliver on the need of the population, and also the performance is improved over time. Next. Rwanda has implemented several programs and also have initiated several reforms to be able to achieve the mission, to be able to improve the lives of the people. And some of the key health sector reforms include the decentralization of healthcare services, where so that services are available at the lower level of the healthcare system, are available at the community level. There is also, we talked about introduction of health insurance schemes. We have several insurance schemes, but the major one is the community-based health insurance, which covers majority of the Rwandan population, especially the poor and people working in the informal sector and informal settings. And the CBHI, as of now, covers more than 85% of the target population. The government has also implemented several health financing reforms, including the performance-based financing and so forth. And also the primary healthcare system or the health sector system in general have a very strong sector-wide approach to ensure alignment of resources, ensure alignment of strategies, so that the strategies and what is implemented speak to the national priorities. Here we have the Vision of 2020, we have different plans. All of these are put together to guide the implementation of healthcare interventions, but also to make sure that it helps the government to meet the needs of the population. Next. Allow me to pause a little bit to present to you how the healthcare system is organized in Rwanda. As Dr. Kechi presented, we have a very clear diagram in place where the base is very big and also narrow as we move from one level from lower level to the upper level. So we have at the lower level, we have household, we have villages, we have cells, sector, districts, and at the national level. So basically, as I mentioned, at each administrative level, we have a corresponding level of healthcare system. At the lower level, at the village level, we have community health workers, we have health posts, and also we have health centers. At district level, we have district hospital, and at provincial level, we have provincial hospitals. And at the national level, we have the Ministry of Health, which is responsible for establishing policy, monitoring and evaluation, and also generally involved in the resource mobilization, coordination of program, capacity development, and so forth. So basically, at each level, there is a clear delineation of roles and responsibility, and also the types of services offered are very well differentiated. Next. So, and I would say that based on that pyramid that I have just presented, I would say that in Rwanda, the primary healthcare system is the cornerstone to address health inequalities, to improve health outcome, and also to achieve UHC. It is the vehicle, it is the engine to achieve UHC. And to be at that level, the government of Rwanda has scaled up the construction of health facility at all levels in different parts of the country, following the decentralization strategy of the healthcare service delivery. So whereby we have seen that every administrative level of the health system, from national to the lower level, we have infrastructure, we have facilities to cater to the need of the population. As I say, the primary healthcare system in Rwanda is composed of the network of community health workers, the network of health posts, and the network of health centers. So basically, a health center is located at the sector level, and it covers about 200 20,000 people, and the health post and the community level are more at the lower level of at the community level. Next. So I will say that the primary healthcare, which is composed by health posts, health centers, and community health workers, they deal with more than 90% of all outpatient visits within the healthcare system. And allow me also to present that sometimes I want to clearly define that health posts and health centers, they quite provide similar services, but when you look at the package and also the number of staff, we realize that health center has more staff compared to the health post, and also the package is more. They can also cater for inpatient visit and other services. So the package are a little bit similar, but the package of health center is more expanded compared to the healthcare post. I want also to emphasize that over the last few years, the government has again decided to further decentralize the primary healthcare services and also improve geographical accessibility to healthcare services, because the government feels that people should not walk more than 5 kilometers in terms of distance, and also should not work more than 1 hour to access healthcare services. So given that vision and also that based on that understanding and vision, MOH, Ministry of Health, and the local government authorities were given new targets and also were mandated at least to have 1 health post in every cell at the lower level of our healthcare system. So in Rwanda, we have about more than 2,000 cells, and we have seen that the government is making efforts, working together in partnership with local government authorities, with the private sector, and the community to expand the availability of healthcare posts. Very recently, we have also seen at the primary healthcare the innovative ways of providing healthcare services. The Ministry of Health has recently introduced the digital healthcare services, where people can get access to healthcare services using mobile phones. So basically, this has improved the availability of primary healthcare services, and also has improved the availability of access to needed care, especially during the lockdown period. Next. So as I said, you will realize that from this table that majority of new health infrastructure has been put at the lower level of the healthcare system, in partnership with local government, partnership with private sector, and in collaboration with community leaders. We have seen improvements, we have seen increase in the availability of health centers, increase in the construction of health posts. You can realize from this table that by June 2020, we have about 510 health center and more than 1,000 healthcare posts. That because I have just mentioned, the government, the MOH, and the local leaders have the mandate to make sure that services are available at the lower level of the system, and each cell has a health post to meet the need of the population. Next. So when it comes to human resource for health, we realize that at the primary healthcare level, we have general nurse. They are the one who are providing healthcare services, and the majority of health posts, the one that are at the lower level of the system, they are run by nurse. This is part of the strategy to use minimal HR resources by task shifting. Next. Who are the key common providers? The key providers, we have public primary healthcare providers, we have faith-based providers, we also have private for-profit primary healthcare providers, which are mainly at the healthcare post level under what we call public-private community partnership model. And to be able to access services at the primary healthcare levels, patients are not required to register with a specific public healthcare providers, but there is a very strong gatekeeping mechanisms. That is to say that patients need to have a referral, not to move from primary healthcare provider to the secondary care providers or to the specialist. And also, given that majority of Rwandan population are beneficiaries of CBHI, they can have access to anywhere, can have access to primary healthcare services anywhere because there is a roaming system. But again, as I said, a referral note is needed to move from the second level. And the referral system, you have some exception in case of accident, medical emergency, referral system, the reference note is not required. Next. In Rwanda, we have a very strong engagement of private sector. They are involved in the provision of services, in the supply of medicine and equipment, and also in financing. And we also find that under these public, private, and community models, we have health posts across the country. We have health posts in urban, rural, and remote areas. And these health posts, they have, given that they are managed by a private nurse, they have a budgetary autonomy. They can hire staff, they can fire staff. They also, given that autonomy, but they are required to get medicine and health commodities in the national system to ensure the affordability of health commodities at the health post level. Next. So I would say that we have the benefit package. Every level, as I said, we have a primary care level, we have secondary level, tertiary level. At each level, we have a benefit package. At the health center, we have the minimum package of activities which focus on promotional, curative, pharmacy, laboratory services, and but we don't have medical doctors at primary healthcare, but outreach campaigns are very common, whereby community members can have access to specialized healthcare services. I will also we have noted that some of the health centers offer specialized services such as air care, dental services, and so forth. And also at the primary healthcare, we have trained community health workers who provide especially maternal and child health interventions, and they were given mobile phones so that they can use to report and also to call ambulance and also to communicate with the other levels of the healthcare system. Next. We have again in the country, we have when it comes to accountability and governance, we've realized that the primary healthcare system is well governed. The health centers and health posts, they are supervised by district hospitals, and the external supervision generally includes evaluative supervision and formative supervision, and also external supervisors are generally composed by members of the district health management team. And most of the time, given that we have to maximize the available resources, both supervision generally are combined. On top of that, every head or manager of a primary healthcare facility has to sign a performance contract with the local entity. They have to sign what we call imihigo, and they have to sign, and this performance generally is signed by a head with the district hospital and also with the local entity, so that they can deliver on the need of the population, improve CBHI uptake, and also make sure that the quality of care is improved over time. So at the facility level, each individual staff at the primary health care level, it also signs a performance contract with the head of the facility. All these accountability mechanisms, in part, we have realized that they have contributed to improvement of quality of healthcare and also improvement to the accountability and also to the need of the population. Next. Allow me to give you a little bit overview how the healthcare financing indicator looks like in terms of the population. The life expectancy has improved over time. Rwanda has achieved the Abuja Declaration, and also the spending on the primary healthcare is very high, around 40% of health sector expenditure are allocated to the primary healthcare level. And also, I would like to insist that given that geographical accessibility and financial accessibility in the country, that this is reflected in reduction of out-of-pocket payment in the country, where out-of-pocket payments stand around 90% as based on the available, the latest available evidence. Next. How primary care providers are paid? I have, based on on our context, I would say that we have around 5 payment methods. There's a government budget, especially line item budget, to cover salaries of primary healthcare providers. We have performance-based financing, which is done on quarterly basis based on facility performance. And I want to insist that the PBF in our setting is only used to top up salaries, to increase motivation and retention. Previously, sometimes facilities were allowed to maybe to hire additional staff, to pay, maybe to purchase medicine, but as of now, it's only used to top up salaries. We have also the disbursement from health insurance scheme, especially the CBHI scheme, which covers the majority of the Rwandan population, where the payment for primary healthcare provider is based on fee for services across all the schemes. And the resources from health insurance are generally used to purchase health commodities, to buy consumables, and also to pay some contractual staff. Some facilities also benefit from donor funding, especially targeting HIV and reproductive health services. And also we have out-of-pocket payment. As I said, it's relatively very low, so that the poor can also, and the marginalized population can also have access to needed healthcare at the primary healthcare levels. We also emphasize that the poorest households in our country are very well known. They are given free healthcare and fully subsidized by the government, and also by resources from donors. And also prisoners and refugees are also entitled to free healthcare services based on existing regulation in the country. Allow me to present the key achievement and lesson learned in the past 20 decades in Rwanda. So we have seen that the primary healthcare system has improved access and utilization of central healthcare services, and thereby has contributed to financial protection, and also has contributed to the achievement of major indicators of EHC. This is because the 8% of burden of disease are addressed at the primary healthcare, and also more than 90% of OPD visits happened at primary healthcare system. We have also realized that the primary healthcare have contributed to the achievement of MDGs, and this can be attributed to the commitment of the leadership, and also the consistent implementation of critical interventions. And we have also learned that the functioning of the primary healthcare system is generally based on the partnership and the collaboration between national and the local government, but also other stakeholders, including the members of the community. Next. So this is an overview showing you how the Rwanda has achieved remarkable improvements in health indicators in the past 2 decades. So allow me to conclude by sharing some of the challenges. The primary healthcare system is facing now. So there is a high turnover of primary healthcare providers, especially in rural and remote areas. We have also, the country is also experiencing a significant reduction in external financing for the health sector, and thereby meaning that also the available resources for PBF also has declined over time. Another major challenge is delayed reimbursement by CBHI bills due to the long verification process and the financial difficulties faced by the scheme. This is because the scheme is still using a paper-based system, and the scheme has also accumulated financial deficits over time. Another challenge includes as a country, we are experiencing epidemiological shifts. And this epidemiological shift is also associated with an increase in the cost of care, and where the burden of diseases show that there is an increase in non-communicable diseases. Also, the ongoing COVID-19 pandemic also has put immense pressure on the primary healthcare system due to increase in the number of cases and deaths that we are experiencing now. Next. On this note, I will say that, let me share with you some of the lessons learned. The primary healthcare system, as I mentioned from the beginning, is the vehicle, is the programmatic engine for the country to achieve UHC, to reduce inequalities. But this is only possible when there is increasing allocation from the government, because the primary healthcare system should be supported by the government to be able to improve the quality of healthcare system. As Dr. Kenchi mentioned, currently the country is trying to investigate how capitation can be introduced at the primary healthcare level to increase availability of funds to finance the system. We have learned that stakeholder engagement is very critical to adequately finance the primary healthcare, and also synergies is also very important to finance and to ensure availability of primary healthcare services. There should be also a clear roles and the definition of accountability, the definition of roles and responsibility, and it's very critical to minimize corruption at the primary healthcare system. Therefore, accountability mechanism is very important to ensure proper functioning of the primary healthcare system. Again, I will emphasize that trust in the public healthcare system is vital to move toward UHC. And on these notes, I say that primary healthcare can be a vehicle to improve financial protection of citizens and to achieve UHC. On this note, I thank you very much for your kind attention. Merci beaucoup.
Thank you very much, Stella. That was a really super presentation. Dr. Amriera, any comments? I particularly found, that I think everybody recognizes, if you look at the chat, the commitment of the Rwandan government to primary health care is quite evident, even in the Abuja Declaration, and that it's a kind of commitment to it. I think to health generally, I think what we need to do is understand how much to health itself as a cost is being allocated. It looks substantial, but I think that's an important indicator for us to go forward with. And I think the fact that you are both involving the private sector and the community seems like strong, sustainable processes. I'm just wonder about a question broadly. Is there any reflection on the quality of care, especially with NCDs that you mentioned, where quality of care can impact broadly, on the way in which patients respond? Are there any studies being done on that, on the quality of care and the questions related to that, Stella? Just a quick question. I think what we'll do is maybe let's do that. If you don't mind, Stella, are you in a hurry to leave? Can we perhaps keep the questions to later? Stella, would you be able to hang in there for us, or do you need to leave? I hope that Stella can unmute herself. Let's hope. Let me just quickly check. I think, Stella, if you can unmute yourself. Yes. Okay.
I was muted. Yeah.
Yeah. No, sorry. I was just preventing other people from unmuting themselves. Go ahead, Stella.
Yes, yes.
If you can you hang around, or would you need to leave immediately?
I think I can stay a little bit. No problem.
All right. Then let's see what. Go ahead, Mughira.
Yes, I would like to strengthen one point. Rwanda, I have been visited Rwanda 2013, and I've really amazed with the health system there and with the health insurance in Rwanda. And as you said, that the political commitment is very obvious there. It is, I think, it is regarded as a very solid asset for the progress of healthcare system in Rwanda. Another thing is a clear vision. We notice that a clear vision for the whole sectors, for the whole public sector in Rwanda, and especially for the health sector. And each sector and each department and each individual really knows what he will do in order to achieve the Vision 2020 at that time. So I think Rwanda has these two potentialities that make Rwanda a very strong country as far as health system is concerned. And really, it is very obvious now from the result. The political commitment is not a talk; it is translated into actions. That 15% or almost 16% of the annual budget is allocated to the health system, and over that 40% is allocated to primary health care. And this is a very good commitment, and we need all African countries to follow Rwanda model and other also successful models. Thank you.
No, thank you very much. I think that we'll leave the questions. There are some in the chat group. Unfortunately, somehow our Q&A didn't set up, but we'll try and sift through. If you have any questions, please feel free to add them into the chat. In the meanwhile, let's ask Dr. Amafeni, to share thoughts from Ghana and see what that sort of thinking provided. And then we'll see how to review questions and then break up into groups. And it might be a little shortened because of our interruptions, but we do want you to engage as a group around how do we strengthen. Oh boy, are we having another person that's mucking around? Okay, let's proceed. I hope that we haven't got someone else again mucking around with us. Okay, let's proceed. Amma?
Okay. So thank you very much, everyone. And in a short while, I will try and go over our experience towards achieving universal health coverage, and also reflects on some of our payment reforms for primary health care. Next slide, please. Next slide. Okay, so this is putting our country in context and also looking at how we perform vis-a-vis South Africa, Kenya, and Nigeria. One of the things I would also want to point out is that our GDP growth is contracting, and this is not just in Ghana, but in South Africa, in Kenya, and Nigeria. You can see that our economies have been very hit by the COVID pandemic just over 1 year. We still are falling behind on the maternal mortality indicator, still very high at 308 per 100,000. And then out of pocket, if you compare with other countries in the sub-region, apart from South Africa doing well, we are also not doing too good. Next slide, please. So our health system in Ghana is pluralistic. It also follows a decentralized method, just like Rwanda's. Next slide, please. So we move through the multi-level system from primary, secondary to tertiary levels. Within every district, we have a sub-district, and we also have community health planning services, which we call CHIPS zones. These are supposed to ensure that communities have access to healthcare. And so these CHIP zones are across, there are about 10 to 15 CHIP zones within a district with a population of 100,000 people. If you look at the public-private breakdown, 61% of our facilities are public, 31% are private, and the others are faith-based. Next slide, please. So this community-based health planning and services program started in 2005. And the idea was to reduce health inequalities and promote equity of health by bringing healthcare closer to communities. And over the years, as you can see from this graph, from 190 CHIP zones that we had in 2005, we currently have about 5,547 in 2020. So you can see the effort that is being made to increase the number of community health posts to allow our communities to be able to reach care. Again, there are questions about quality that we'll talk about later, but then invariably, the efforts are being made to open up our communities to good quality care through the system, which has been going on since 2005. There have been a few challenges, but I'll highlight those later. So Ghana has a definition for primary health care, and this is a whole of society approach to health. And the aim is to ensure that we are offering the highest possible level of health and well-being. And this is being equitably distributed across people's needs as early as possible, from health promotion to disease prevention, to treatment, to rehabilitation and palliative care. And so far, we have made some progress, but again, there's a lot to achieve. If you look at our key health reforms, especially when it comes to financing, we were all part of the structural adjustment programs that, empowered governments to introduce health payments. Some of the effects of this particular strategy was that people could not pay for care, and so they moved away from using our health facilities. Next slide, please. Yes. So in 2003, there was a lot of debate around this whole use of fees, and without fees, without cash, you couldn't have your health care, and there were a lot of agitation. So even though it has a lot of political underpinning, the whole idea of moving away from a cash-based system to a prepayment of health services became very, very focal in our discussion. So in 2005, the National Health Insurance System was introduced. Next slide, please. And prior to my discussion about the health insurance system, which I will do in the next few slides, I just want us to have an idea of how the flow of funds happen within the Ghana health system. So you have the Ministry of Finance and Planning and Economic Planning, and then you have the Ministry of Health, and then you also have our development partners. Funds are being channeled through all these different agencies into our National Health Insurance Scheme. And the National Health Insurance Scheme also makes payments to the Ministry of Health. And so there are direct payments that are coming through from development partners straight to health facilities. Some households still pay user fees to health facilities and pay premiums to the National Health Insurance Scheme. So you have an idea of how fragmented the flow of funds is in Ghana. And as I develop my presentation, you understand why we have problems when it comes to financing at the PHC level. Next slide, please. So technically, according to the breakdown within the Act 852 of the National Health Insurance Law, the health insurance is tax-based. It is supported by 2.5% of VAT, which forms about 72% of the tax base. And then you have contributions from formal workers, which make up 20%. So the premiums are just under 4%. And then you have resources coming from other categories that have been listed on the side. So the National Health Insurance Fund will make payments to the healthcare providers, and then it will cover its operational costs, and then it will also make payments to the Ministry of Health. So this is how the National Health Insurance is structured according to the Act 852. Next slide, please. So coming back to the National Health Insurance Scheme, the idea, as I said before, was to grant access to good quality health services. By law, we have three different schemes. We have the public mutual health insurance schemes, which are on the district level. And then we have private mutual health insurance schemes. And then we have private commercial health insurance schemes. The district health insurance schemes are state funded, which is part of the National Health Insurance, which is operated within the National Health Insurance Fund and under its authority. It's operational in all the districts in the country. All residents in Ghana are encouraged to enroll in one of these three schemes. One of the things I need to also emphasize is that there's no provision made for enforcing enrollment. And so in the next slide, you will see the share of people who actually are part of the National Health Insurance Scheme. The private health insurance schemes have very few people joining them. Naturally, these are for more formal workers and those who have higher incomes and can pay the premiums that they require. Next slide. So within the National Health Insurance Scheme, we do have exemption groups. Children under 18 are exempted. The elderly 70 years and above are exempted. There's exemption for those who are identified as poor. Again, there are problems with identifying the poor within our context, and that has also come up several times. Expectant mothers are also exempted from paying premiums. So this, if you look at the graph, you would see that the scheme is more than half supporting exempted groups, which also it shows the challenge that the scheme is going through. More than half of the members are exempted from premiums and exempted from paying premiums and registration fees. Next, please. So the benefit package covers 95% of the health conditions affecting our population. So outpatient services, inpatient services, oral health, eye care, maternity, emergencies. It excludes cosmetic surgery. HIV retroviral drugs are not part of it, and all these other treatments, cancer treatment, organ transplants are not part of the benefit package. One of the things I need to point out that is exclusive to our system is that our benefit package is the same for every individual who is registered as a member of the scheme. There are no levels, or we don't have different packages for different groups of people. It's the same benefit package for every individual within the scheme. Unfortunately, our service coverage index is quite low at 47%. And even though we are saying we are covering 95% of health conditions, we are actually not providing services that cover all of that. Next slide, please. So how are we reimbursing our service providers? We're using both fee-for-service and then DRGs. So at the facility level, the total cost of service, supplies, and medicines are compiled in claim forms, and they are sent to the district scheme office for payment. The NHIA provides accreditation to the facilities, and then tries to use this accreditation process to ensure that the facilities are providing quality standards of care to their clients. Again, there are negotiations to move that aspect to the HEFA, which is a new health facilities regulatory agency. Next slide, please. So we have a mix of provider payment mechanisms. For medicines, we have fee-for-service. For secondary and tertiary care, we have the Ghana Diagnostic DRG capitation. Please, can you keep on pressing? Yes. Okay. Thank you. So we have, in 2005, one of the things I need to point out is in 2005, we had fee-for-service for everything, for both the services and the medicines. And then in 2008, there was a revision. So for outpatients and inpatient services, there was the Ghana Diagnostic Related Groups that was used to pay for these services. But the medicines have remained on fee-for-service mechanism since the inception of the scheme. In 2012, there was a move towards capitation. And this started out as a pilot in one of our regions. Unfortunately, there was a lot of pushback from both the clients and the providers. And so that has been stopped. This process has been stopped, and we no longer have the capitation within our system. And we are still applying the DRG for inpatient, outpatient, specialist, and emergency care. Next slide, please. So again, like many other countries in Africa, we do have huge gaps in our human resource capacity. A provider capacity mapping exercise that was undertaken about 6 years ago shows that only 12% of our providers were able to meet the criteria to deliver on the full package within the benefits package of the NHIS. Next slide, please. So we are reflecting on the impact of primary health care, the NHIS on the primary health care. And one of the good things about the NHIS is the fact that it is one single pool, and it's reduced the fragmentation within the insurance system for sure. As a single pool and a purchaser for insurance for its clients, it has been able to merge all these different pools together. And so that has been a good thing. But again, there are lapses when it comes to its potential as a single purchaser, because there's still fragmentation within the financing system. As I showed you before, the government of Ghana financing through salaries, through payments to the NHIF, through goods, through services, through credits. And then you also have out-of-pocket payments. You also have donors pushing money directly to facilities or to programs. And then you have private companies, communities also coming in with different financing sources. So yes, we would really have loved to have the NHIS become the single purchaser and benefit from that strength that having a single purchaser would have given us as a country. But unfortunately, we still have this fragmentation on several levels. When it comes to inequities, yes, we hoped that the entire population will be covered by the NHIS. Unfortunately, that has not been the case, but we have seen improvement over the years. Currently, according to our latest holistic assessment report, just over half of our population is covered by the health insurance scheme. But still, we are very high on out-of-pocket payments. And as I mentioned before, our service coverage index is quite low. There's also the emphasis on curative care and less on preventive health services, which also needs to be looked up when it comes to the National Health Insurance Scheme. Next slide, please. So we are moving towards UHC. Ghana is defining its PHC within the UHC roadmap as we speak. And so the idea is to ensure that there are essential services for the population, manage clinical and public health emergencies, improve quality of care and information management. One of the things I want to point out here is that there's work towards allocating an additional 1% of our GDP to primary health care, and also reforming the NHIS to improve efficiency. And again, the idea that the PHC has been recognized in its role as an effective mechanism to reach so many people with good health care, that the drive is to allocate at least 50% of our resources towards PHC expenditure. So the framework to shift care to a more people-centered health system and UHC, it's in motion, and we are hoping that that will become the reality in a few years to come. Next slide, please. I think I've mentioned most of this, but one of the things I wanted to point out is the third one, which says that given the current budget available for the NHIS claims reimbursement, it is unlikely that all primary care interventions can be covered. And so we face a financing challenge. Undoubtedly, the pandemic has shown up so many frailties in our health infrastructure. And there has been call to invest more in health infrastructure. One of the things I have highlighted here is that, yes, we want the construction of new hospitals, but we do not want them in the same places where there are existing health facilities. There are so many underserved areas in our country that deserve to have facilities, and we hope that these will be the channels through which we improve access to primary health care. So I leave this, next slide please, presentation with a few reflections. One of them being, can we adequately pay for quality services and products without escalating prices? Because that has been one of the biggest challenges. How do we control escalating prices when we still want quality of services and products? Do we have institutions that can judge when we have value for the money we spend at the PHC level? And then this is to all of us. Why are doctors and nurses so reluctant to work in some of our PHC facilities? Are we incentivizing them enough through our payment mechanisms? And who else should be in the room? Do we have patient groups, private sector CSOs, and others in other sectors, transport, water, and environment, who need to be part of this discussion so that we can ensure that PHC is financed the way it should? Thank you very much for your attention.
Thank you very much. I think let's just make sure our Amrita is able to speak. Amrita, you're able to talk. Yeah.
Thank you very much. Again, I think this is a very successful story from Ghana. First, if we talk about the financing itself, and in particular to the collection of revenues, I think Ghana uses different modalities, including taxes, contributions, and user fees. And I think this is a credit, not a drawback for the health system. Because if you are talking about different resources, now we are talking about different resources of revenues rather than fragmentation. So I think this is very, very good. Again, in the pool, they have a single pool. This is very excellent. And Ghana, again, has a very successful scheme of social health insurance. Fortunately enough, I also had the opportunity to visit Ghana physically and see the system there working on the ground. And I think they are very successful in terms of the coverage, in terms of the benefit package, the generous benefit package that they offer. 95% of the cases are included in the benefit package. But I would like just to to ask Anna about the, do you agree with me that the rest, which is 5%, is really has great impact on the budget of the individual, or mainly the out of pocket? So this is the remaining is few, or 5%, but really this is the conditions that render the individual in catastrophic payment. So what is the way forward for Rwanda, for Ghana health system or health insurance in order to include these services in the benefit package? And I highly recommend this not to have another pool. This will make fragmentation. If as our case in Sudan, because we have fragmentation in pooling. So if you include it in the package, in the single purchaser, which is the social health insurance scheme there, I think it will work better. Regarding the purchasing, DRG, I think Rwanda is the icon of Africa as far as the modalities of purchasing of healthcare services are concerned. But do you agree with me also, DRG is not suitable for primary healthcare? Yeah, we can regard it as a
Mughira, I think
bundle
she said it's not for primary care. She mentioned it's for hospitals.
Yeah. For now it is for hospital, but in the primary healthcare also they use like bundle fee for service. Sure. They call it also DRG, as we have the experience there. Last thing is I am very fond of Ghana in the field of research. Everything there is decision mainly is driven by evidence-based, and if you search our site, the sites of researches and so on, you will find many publications arise from Ghana, and this is very, very good assets for Ghana. And I think I conclude my remarks.
Well, thank you very much. Appreciate that, Dr. Abdullah. I think, being in the NHIF of Sudan, I think it's a pity we can't get you to talk a little bit more about the work you do in Sudan as well. Time's not allowing us because of these little disturbances. I know there are quite a few questions. I've asked for Dr. Oludare Bodenrun to just quickly share the questions with us. I must just make sure he's able to speak, and he can just quickly read out those questions so that we can just get the feel for some of them. So we'll try to answer them, just a few of them. I think the groups will be there, and I think some of the participants, panelists will be there as well. So you could use the opportunity. But I think the group is going to be a discussion of a question of how do we strengthen it. And I'm sure it's all these questions will be part of the discussion. We're not going to have it also too long. So please, if you can bear with us. Odare, do you have any questions you'd like to just raise out of the discussion or the chat? Yes, thanks.
Yeah, thanks, Shabir. So I have a couple of questions here, but I will start with questions that are more PHC related. One of the questions here for the Rwanda presentation talks about how are the community health workers paid from the government and PBF. I think there's a mention about the fact that the PBF payment mechanism goes as top up on the community health workers' salaries, which comes from the government. So the question is how does that work? And then there's another question here for Rwanda talking about what are the indicators and means to assess the achievements at PHC level. So what indicators are used to assess PHC performance? I think that's basically speaking to what essentially is in the performance contracts that is signed at these levels. And then for Amma, we have a question here about Ghana. How do we get skilled healthcare workers to focus on PHC facilities in the rural areas? So basically, and I know that in the chat session also, we have, I think I saw some notes around the experience in Sudan, where there is a challenge about scarcity of health workers or reluctance of health workers to work in rural areas and things like that. So what has been Ghana's experience in ensuring that there is access to care in rural area with the full complement of staffing? A general question here finally talks about what is the modality for identifying the indigent? And this applies both to Rwanda and Ghana. What is the modality for identifying indigents who are exempted from paying premium? In the case of Ghana, where it's tax financed, which essentially should mean probably everybody should be covered. What's the exemption approach? And in the case of Rwanda, which is highly targeted, what's the targeting mechanism? Yeah, those are just a summary of the questions. Yeah.
Thanks, Tara. Appreciate that. Just to mention also the questions, the presentations, as well as the flow of the chat will be available on the website where you registered. So don't stress, we'll provide that to you. So over to you, Stella, and then Anna, to just respond to those questions. And so please feel free to add your chat to, more chat and responses. We'll capture that. If the discussion is not enough, we want to use this information you're putting into the chat as a way to get a sense of what you do. So, there's a bit of debate going on there. Please engage in that. I think use the opportunity. Thanks, Amma. Stella first and then Amma. Sorry, I need to make you unmuted, sorry.
Okay. Thank you very much for this opportunity to respond to some of the questions from the participants. I would say that the community health workers, they play a key role in terms of being an interface between the primary healthcare and the community. And the program was introduced in 2007, and community performance-based financing was introduced in 2010 to sustain community system. As I said, we have around 45,000 community health workers trained countrywide, and which give health intervention at the community level, especially maternal and child health interventions. And they are volunteers. They are not given salaries. They get a bonus. They get a financial compensation on quarterly basis. And there is, as I mentioned, we have the DHMT team and also a PBF team in place. We composed of different actors in the healthcare system who have the mandate to evaluate the performance of the primary healthcare providers, but also the performance of community health workers. And the key and the assessment focus on quantitative and qualitative indicators based on service rendered, and also majority of indicators are predetermined. So therefore, based on the performance achieved, they are going to get a bonus on a quarterly basis. And for the sustainability purposes, community health workers coming from in the same sector, in the same catchment areas, were grouped into cooperatives. And those cooperatives run income generating activities, which means that at the end of every quarter, they get a bonus. The bonus is channeled through the cooperatives. So there is a proportion of the resources they receive through the community PBF. A certain percentage goes to finance the cooperative activities, and another percentage is given to community health workers as an individual compensation. I think that's how the community PBF works in Rwanda. On the second question related to indicators to assess the quality or the quantity of services by primary healthcare providers. Yeah. PHCs. Yeah, we have a long list of indicators, including.
Would you provide that to us, Stella, and and I can put it up on the website.
Okay, definitely. Yeah.
Sounds
so
good. Yeah.
We have clear guidelines, a clear document that specify key indicators that are assessed on regular basis to improve the quantity and the quality of care at the primary health care level. How do we, as a country, identify indigenous and the poor people in the country? So in Rwanda, we have a very well functioning system called the Obudehe system, which is a system that aims to help the government to do a socioeconomic classification of the household. So every household in Rwanda belongs to a socioeconomic category. So based on assets, based on income. So the classifications is done by community leaders with the involvement of community members. So definitely the system is, yes, it has some challenges, but at least we have a basis to classify individuals into categories based on socioeconomic status. That's what I can say. Thank you. Over to you, Shabi.
No, thank you, Stella. Appreciate the comments. Do you want to respond as well, Amma?
Yes. So one of my key questions was around how do we get health workers to work within the primary healthcare facilities in rural areas. That has been one of our biggest challenges. I know for sure that the Ghana Health Service has placed some incentives for some of our doctors to move in the rural areas, but it hasn't been very successful. Most of them are still in our urban cities. We still have huge HR gaps when it comes to our rural areas. And so I thought that we could find a way of incentivizing them beyond just the financial aspects. But then this will have to be the whole of society approach again. If you send a doctor or a midwife or any health worker to a place where there are no roads, no good schools, then it becomes very difficult for them to move, especially when they have families. And so these are some of the things we need to start engaging the whole development process on. If you want us to get the best, you really must get the system right. When it comes to the 5%, yes, I understand that the 5% could be very catastrophic. For example, if you end up with a cancer that is not covered by the NHIS, yes, the payments are catastrophic, and we are well aware of that. Now, I can't for sure tell you how the NHIS is making any efforts to cover the 5%, but I know that for family planning, there's been a lot of advocacy around it so that the NHIS will eventually make the effort to cover it. But a lot of families end up with catastrophic health payments because they end up with diseases that are not covered by the NHIS. And that has been a challenge as well. Thanks.
Okay. Now, we were supposed to break up into groups, and I'm just a little bit unsure how concise the discussion would be, and we're running into time troubles. There are some people who have put up their hand. I'm going to just say we'll need to just see if we can get some comments and conversation going, and we're going to have to perhaps ask you to put some of your thoughts into the chat group as well. And I think we will just raise some of the discussions in the panel and just see if we can debate it like that. So feel free to either pick up your hand or to put some comments down. And we use this discussion, in fact, to take this process forward, considering that we only have literally, I think we can only go about to 3:30. And I don't want us to break up, to click quickly. So let's start with Akan. Akan, you have your hand raised. I'll give you a chance. Let's just keep the comments short so that we can allow more people to contribute. So Akan, you can go next first, and then Prityosa, you've got your hand next. So Akan, any comments?
Yeah.
And I'll pick up the conversation also in the group. So okay, go ahead, Akan.
Okay, Shabia, well done everybody. The last speaker spoke about how we can get doctors involved in primary health center, which is still an issue in Africa. What we did in my community-based health initiative was that we partner with the community health unit in a teaching hospital, and we liaised with them, and it was part of their MOU that they'll be sending doctors to the primary health center, of which we were working on weekly basis. So that helped us to bring in doctors on weekly basis to a primary health center. And the doctors in the primary health center, doctors being in the primary health center also make the community people to utilize the services at the primary health center. And the second aspect was that we also liaised with the Ministry of Health, and they were sending us the doctor corpus, people that are going for national services, the doctors, and they come there and they do their 1 year internship in the primary health center. So this can also help us, if we can liaise that way, can also help us to have medical doctors in the primary health centers.
Thank you, Akan. Sounds like a useful idea. So can I just turn the question slightly to Stella? Stella, in your presentation, you talked about doctors are limited to the district hospital. Do you also see no need for doctors in the primary care setting of non-hospital care? And the other question would be, is the private sector doctors, I mean, are they there, and how much of the population uses private care from such doctors? Can you respond to that, Stella? I mean, for example, you mentioned private dispensaries. Are there any doctors in those private dispensaries? Sorry, Stella, I must ask you now. Let me see if I can quickly unmute you as well. I'll make you co-host so you can actually do it yourself. You can unmute yourself now.
Okay.
Yes, go ahead.
Thank you very much. Yeah, thank you very much for your good questions. As I mentioned in my presentation, I indicated that doctors are not permanent, are not working the primary care on permanent basis. But we have realized that in the private dispensary or private clinic, they can have scheduled doctor consultation on some specific days, on specific services. But when you look at the guidelines, Ministry of Health guidelines, the primary healthcare is generally dominated by nurses. And we have to recognize we still have a limited number of doctors in the country. And with the human resource HRIH program in the country, we are trying to train as much as many doctors, many healthcare providers who can provide services at the primary healthcare level. But the major challenge we have now is a limited number of doctors. But some of the services that are needed, that are provided by doctors, can be provided by nurses. Let's give an example. We have a program where now ultrasound, like where for antenatal care system, some of the health centers were donated ultrasound. And this task is not performed by a doctor, it is performed by a very well-trained nurse. So what we did is just having a mentor through a mentorship program, a medical doctor, we train nurses to provide those special services at the primary healthcare level. So I would say that despite not having doctors at the lower level system, I say that the quality of care is very much appreciated based on some of the patient satisfaction survey that are conducted by the Ministry of Health, and also the referral system is very clear. If the primary healthcare level is not able to cater for the need of the patient, the referral system is very clear enough, a client can be easily and very quickly be transferred to the next level. We have ambulance system, which is working very, very well. Majority of district hospitals have more than 4 ambulances to cover to support health centers. So I think they are not enough, but it's not again a major challenge. As also I mentioned throughout my presentation, the district hospitals, in collaboration with health centers, they organize outreach activities so that they can also be on the ground, meet clients, organize the referral system to make sure that there is no delay in terms of accessing the needed healthcare. Thank you.
No, thank you very much. Just a quick question, and Stella, you can quickly answer this. What's the percentage private and public service providers, perhaps in terms of health expenditure overall in the government, in the country? What's the percentage public-private mix?
Thank you very much. I would say that the private contribution is still very limited. We are having our system is generally funded by the public sector. Okay. But with the increase of, we have seen in my presentation, I have shown how the private dispensary has improved, but you can see that the private sector is not very strong enough. So it's a government-dominated program, which means that the private sector contribution is still very limited when it comes to financing level. So, now we are with the current strategic health financing strategic plan. One of the areas the government is trying to work on is how to actively engage the private sector, not only in service provision, but also in financing, supply chain, and so forth. So basically, that's the trend is progressing, but it's not. It's generally it's a system predominated by public.
No,
system.
that sounds fine.
Yeah.
Pretiosa, you had your hand up. I've unmuted you. You can go ahead and share your thoughts and share your comments. And then Farhan has got his hand up. We'll kind of slowly go to that. And go ahead, Pretiosa.
Yeah, good afternoon. Here in Mozambique, it's in the afternoon. However, I just wanted to contribute on the issue of, I think she mentioned the issue of having doctors not covering adequately in rural areas. I think this is a problem in most of the countries in Africa, even Zimbabwe, where I stay. We used to have such a problem. But as a nurse educator, I feel that if we are going to scale up the programs that are meant for community healthcare nursing, for example, we have the Advanced Clinical Officers Program. Those are actually mini doctors. They perform a lot of surgeries and everything. And in Zimbabwe, we have managed to send those people in rural areas to cover for the doctors' part. And then I wanted to suggest the old system whereby we have the medical school, the nursing schools in the country, let's say in Rwanda, as soon as they qualify temporarily on temporary basis, they're not allocated. The government ensures that every student goes to the rural area soon after qualification. Then they say the government for a certain period, if they want to, after let's say 6 months in rural areas, there's attachment post-qualification, they can change and later on apply to wherever they want to go. But at the same time, we'll be receiving coverage soon after each and every, after completion of every group that we have in the system. Then the next suggestion is that we have got the PC and the primary care nurses. We have found that due to most of the African nurses are very well educated, and due to brain drain, because of the systems in our government, like she was complaining about the developments that are slowed and the roads are bad and everything. I think since we cannot change the economic status of our countries, I would suggest that we create again a PCN. We've got our junior employees, the nurse aides, those people have been in service for quite a long time. We can accommodate them for the PCN program, as well as probably the qualified nurses who want to join the PCN program. I mean, the people who want to join the PCN program, but we make a mandate that this program is meant for rural areas, not anywhere else. And we put rules and regulations that will tie them down to such an extent that they, after qualification, they cannot go anywhere, but they remain as rural nurses. That's another suggestion. Then we have got the community health care nurse. I think we need more schools for community health care workers, nurses. That will also help to ease your burden. Thank you.
Yeah, no, Pritiosa, thank you. I think those were very useful comments. And I just want to pick up from what Stella responded, I think, and what's in the conversation. You know, there's need for doctors, but there's need for lots of other healthcare broadly in Africa. And one of the key things that we have to look at, you know, is yes, we need to expand all of them and look at ways in which to make task shifting, task sharing work in a way that keeps quality up. And how we do that, you know, is best by good teamwork. And that's some of the issues that we want to explore going forward. Is how do we strengthen teamwork? And it's not just a switch of the button. So then I think the issues being brought up by yourselves generally and by Pritiosa is the question of rural. Now we are having a workshop in a few months' time on rural issues in primary health care, which is specifically saying how do we deal with the rural challenges? And a lot of what Pritiosa has brought up as suggestions are actually in that space, and we'd like to have that specific discussion to say, can we actually put in something clear about what we're going to do in rural areas? And I think those are very useful suggestions. They're known already about recruitment and retention of rural healthcare workers. So I'm going to just quickly pick up on a conversation. I know that Farhan and Galaxy Prime have got their hands up, and I just want to quickly ask Amma, if you don't mind just responding to a question or a comment that was put there. I'm not sure whether it's someone from Ghana who talked about, the question of quality, and he seemed quite upset, the quality and the cover. And I'm trying to find that question. I'm not sure, Amma, that you saw that comment. What are your thoughts about the coverage, the fact that, that people are battling with coverage and quality in Ghana, because that's a global problem, isn't it? Is you try to cover the costs and cover the population, and then people say, but we want quality as well. And how are you managing that mix? Do you want to share why you're struggling to get coverage right?
Okay, thank you very much. So I'll keep it very simple. One of the issues that have come up with why people would not use facilities that are covered by the NHIS, for example, has been because of the quality of care. And for example, the medicines that they are given, they would say they are not satisfied with that particular medicine. There's another medicine which is not on the NHIS medicine list that they would rather have. So you have that dissatisfaction coming from the clients themselves, or the hospital saying, we don't have this medicine, it is not on the NHIS list. If you really want it, you will have to go outside the facility and make that payment. So there are a number of co-payment issues that have come up. The NHIS has said that it will clamp down on facilities that are encouraging that mechanism, because it really goes against the very grain of the NHIS. And so co-payments are happening, people are not satisfied, and everybody goes up, we are covered, but we are still not covered. So again, there's that kind of dissatisfaction around the quality of care. And years ago, when the NHIS was implemented, there were issues with long waiting times at the pharmacy, for example, because of the paperwork, but that has been gradually looked at, and a lot of their processes have been digitalized. So it's work in progress, but there are still a lot of teething problems that need to be worked on so that the clients do not feel so dissatisfied with the service. And that in itself will encourage a lot more people to be covered by the NHIS.
So thank you. And often I think that when we're looking at scope or package of services, we define it by condition, but in fact, which is a very difficult thing to do because you're trying to get everything in textbook clear and put out. But the truth is that often the service is limited by the medicine, what is available, either investigation or medicine. And it pretty much more defines the package of services. And if you get sort of simple services, it's easier to define. But the moment you increase the quality, including higher level practitioners, doctors, etc., you start adding the complexity of treatment possible. And that's where you come slightly undone. So let's just ask Farhan, you have your hand up. You can share your comments. And Dr. Abdullah, if you want to raise your hand as well, feel free. Go ahead, Farhan. You want to say something? Go ahead.
Yes, can you hear me?
Yes, we can. Thank you.
Okay, thank you very much. I just have a couple of questions, then directed towards Amma and then the doctor that also presented for Rwanda.
Stella, yes.
Yes. I happen to be a Ghanaian, so I can relate very much with what Dr. Amma has been saying. But my issues really, how do we ensure the implementation of Abuja Declaration that says that 15% of our budgetary allocation should go into health, considering that the government of Ghana has done capping of IGF of about, I think, 20%. So if we really are talking about quality of care and we need to improve upon quality of services that we provide, and then issues of accessibility and availability of critical medicines. And then she also talked about providing incentives to critical care providers. How do we ensure that we achieve this when, I mean, instead of pulling from other sectors to pushing what is already with the health sector, rather taken away by capping the IGF into government coffers that will be taken to take care of other issues. And then vulnerable groups that we have and ensuring that we achieve universal health coverage. I know there is free senior high school in Ghana. I mean, there's a lot of controversy, but coming from that context, is it appropriate that the rich or well-to-do can pay for the poor or the vulnerable that are not able to pay, so that maybe they could pay higher and then a little bit of that can be used to offset some of the debt that could be used to pay for the vulnerable. And then in measuring universal health coverage, how do we measure it? How can we measure it? Because most countries do not really have the capacity to measure coverage and do not, and even the indicators that we're going to measure, what are the indicators? And how do we ensure capacities are built so that we can measure universal health coverage? And what services should we include in universal health coverage? And in terms of financing also, NCDs, how do we finance non-communicable diseases? But she also mentioned the 2021 Holistic Assessment Report. I'm just wondering, did she mean to say 2020 or 2021 because we're just halfway through the year? And then I thought maybe it should be a combination of whatever we have done for the whole year before the report comes up. I guess there's some clarification on that. And so back to the Rwanda, how strict is the gatekeeping that she mentioned? And I mean, if you want to prevent something like doctor shopping, where patient A jumps from one hospital or facility or doctor to another doctor because maybe I went to this facility and they just gave me paracetamol and I think that I wasn't satisfied. So I'm going to the other doctor to see if I could get a better medicine or higher medicine because I have health insurance and I can access multiple providers. So how do they ensure that that gatekeeping is done? And how do you control the ordinary man on the streets? I mean, from just walking from facility A to B, you know, because we could have antibiotic resistance or drug resistance in general if we are just going around picking, drugs from facility A, B, C, so on and so forth? Just a couple of my questions. Thank you very much.
No, thank you, Farhan. I think let me just say that we have time problems. We all want to, it seems a very interesting discussion. We're going to only go on till past. I think, people are dropping off and I don't want it to be a sort of fade away. So we have got some questions that were raised, that Farhan raised. Let's keep it to just one short response. Amma and then Stella. And then we're also very fortunate in having the HOD of Rwanda, Parfait, sorry, Parfait, I'm trying to read your full name, Uali Raya. So who's joined us as well. So we're really grateful, and perhaps he can respond as well. So quick comments, and we are going to see how far we can get with the others who have raised their hand, but I must say clock's down at 3:30, at past the hour. Stella, Amma and Parfait, if you don't mind responding quickly or anything. If not, I'll take the next question and then we'll pick up the comment later. Do you want to respond immediately?
Sorry, yes, let me just do one.
Go ahead. Yep, do one. Yeah.
Okay, so one of the problems we've had with the NHIS scheme is to actually identify who the vulnerable is. Rwanda has a very good system of identifying the poor. Unfortunately for us, we have tried different mechanisms of doing that. It hasn't seemed to work. But then if we say that we are going to stagger the payments according to people's economic standing in society, it will be difficult and we risk fragmenting the pool. So again, we have to find mechanisms of identifying those who are vulnerable and then help them to cushion the burden of health costs. The last thing is, this is actually the 2020 report. In 2020, because of COVID, this report didn't come out. So the 2021 report actually covers 2020 indicators, just to correct that as well. Thank you.
No, thanks, Amma. And I think just quickly, you can focus on the poor by making everybody contribute and making it open to everyone. Then the problem is getting everyone into the system. So I think there are ways in which you can do it. So Stella, if you'd like to respond, and Parfait, if you'd like to comment on anything, feel free. Stella, do you have anything to respond? I think there was a question, but if not, we'll move on to the next. Yeah.
Yeah, thank you very much. I think I will hand over to Dr. Parfait to make comment and provide some additional clarification. Thanks.
I hope, Dr. Parfait, you are not, you feel confident enough. I know I might have noticed you early on, so I'm not sure when you joined the conversation. But you can unmute yourself and just make a comment. Even to say hello, it's okay. All right. I'm not sure that Dr. Parfait's challenge with unmuting himself, but let's just go to the last one or two questions. We've got Galaxy, you had your hand up patiently. I think you can unmute yourself.
Hello.
Yes, go ahead. We're listening.
Yes, I'm Anthony Gingong from Ghana.
Yes.
My is more of a contribution.
Sure.
I think
keep it brief if you don't mind, Anthony. Just keep it short.
Yeah.
Thanks.
Yes, I will. I shall.
Okay. Go for it.
The quick one is that in the case of identification of the poor, and quickly also the issue of quality are issues that are beyond the capacity of the National Health Insurance to handle. Most of them are political, and with this democratic regime, it's difficult to take certain bold actions. That even includes the issue of premium payment. That it has been difficult to increase premium because to make any government in power unpopular. Quickly also, the issue of the availability of medicines goes outside the control of the NHIS. That is because it is the Ministry of Health who controls that aspect, not the NHIS. And then the Ghana Health Service also comes out with the medicines list, not the NHIS. So it is extremely difficult to be able, for the NHIS to be able to enforce them because that is also a different administrative wing altogether. So I think Amma has done a brilliant job, and I agree with what she said. Capitation per se also suffered, not because of protests from the providers, but periodically it was the issue of policy direction based on political ideology. So thank you very much.
No, thank you. Very important comments, Anthony. And I think, yeah, the fragmentation is quite evident. So very important lesson from Amma. Thank you very much. Let's go to Dr. Sorry, whose hand I had up? Weil. Ahmed, is it Ahmed Weil?
Yeah,
yes.
Thank you. Thank you very much.
Yes, some short comment or question?
Yeah, for sure. Because we are hurrying time, thank you very much for the invitation. It's very informative and valuable. I just would like to say that in Sudan, maybe we have challenges in terms of governance regarding the PHC, because our decentralized system, the responsibility is shared between the central level and the district health level. And you know that usually at the locality and district level, there's a problem of the managerials and other. So now we are trying to reform this issue by reviewing and reforming the governance system to make that sure there is a good communication from the central up to the district level. Another thing regarding the HR, here in Sudan, we realize that the communities as general, they didn't reject the contribution or the services provided by the medical assistant in general. But usually their concern and perception is about the availability, the quality, and the comprehensiveness of the services. So now to improve the service provision in these medical providers, we try to train these providers to conduct additional services to make these services more attractive for the population. This is just like training them about conducting a laboratory test, this rapid test for malaria, for diabetes, for others, and also to give them a continuous professional training in the non-communicable disease and others. And really, from 2016 up to 2020, the rate of the people who have been received their medical services from these medical or general allied health workers increased from 9% of the total attendees up to 21% of the total attendees, and this was very clear during the pandemic of COVID. So I think there is a room and there is an opportunity to utilize and to benefit from this HR by focusing training and by providing more incentive to retain them at the rural area. Thank you very much.
Great, thanks for that comment from Sudan. And I think that it provides an opportunity for us to pick up that conversation even in Sudan in the workshop on rural health. I think let's keep in touch around that. Thank you, Ahmed. And thank you for that. So we've got just a few minutes. I'll just see if we can get quick, short comments, and we'll close at the hour. So Dr. Indukumana, sorry, and then Pascal, quickly comments, and then if you can take a minute each, then we'll be closing well. Thanks.
Yeah. Hello. Thank you. Thank you very much for this opportunity.
Yes, go ahead. We can hear you.
Yeah. I'm Ndikumana Sudi from Burundi. I'm a medical doctor, and then dealing like the regional coordinator of junior doctors of Africa in Francophone countries. Right. So by the way, when we talk about the universal health coverage in our situations, I've spent more than 4 years trying to think, and then now we are developing some strategies, seeing that we have to come from theory and then to see really the reality we are facing in our rural areas, even in our urban areas in Burundi, when I can say, how come we can go through the universal health coverage and then we are not involving the junior doctors in our matter? Because, well, since years, I can say since independence, freedom times in our countries, we still have stagnant systems, health systems, which are not welcoming new ideas, new strategy, how we can work, how we can imagine in a referral hospital of 300 beds or 400 beds, we can have only 2 doctors on night shift. It has been like that, and then we are not developing. So for me, I recently launched my new private clinic, which cannot give much response in a whole country, but I analyzed that junior doctors can help us to reach the universal of health coverage without creating, as it said, without creating financial disturbance. Because when I can see doctors.
Well, thanks, Dr. Ndukama. I'm going to stop you there. Thank you. I think the point is very important, is that we need to actually think about young doctors. I'm glad you're here, and that's the first step, and from Burundi. So let's use the opportunity to engage. And I think we are wanting as many people from as wide as possible to join and work ways. So hopefully you can use these networks we've set up to try and help in your country and to get young doctors. Pascal, quickly, I think we don't have very much time. I'll give you the chance, but unfortunately, Yusuf, I'm going to have to pass up. So Pascal, quick comment, and then we close.
Thanks, Professor. Thanks so much for this. Let me go for my 1 minute. I just want to respond that I'm Pascal from Rwanda, Pascal Virindabagabo from Rwanda. So I think this question of reference, that the reference system that a colleague from Ghana has asked, which is very, very important, of what is the gatekeeping system and how the way of bypassing. I think, yeah, he made a point. He has really a very good point. And one of the gatekeeping system is, first, you have to start from a public facility. If you have any health insurance, and mostly community-based health insurance, that you have to start by a public. So the issue, the second thing which prevents that is also the geographic barrier between health insurance. So you will find health facility being like at 20 kilometers from one sector, because each sector in Rwanda is covered by a health facility. So the distance between it will be the 20 kilometer or more than 10 kilometers. So moving from one facility to go to another one to get services, then itself it become a challenge and it become a barrier for that. But we have also seen, as I mentioned, for health facility which are nearby, those kind of things exist, where you can get someone using this service and go there. Even not only that, but passing your card to someone else to go on that one. Now, the way forward for this, Professor, is the National Health Insurance RSSB, which is the council, then Rwanda Social SSA. They are trying to computerize the system, because members has a unique ID. So as soon as you get there, then they will see you that you've been in this health facility yesterday. Perhaps what they will give a period of where if you can use this and that one, because also you are free to use whatever you want. Thank you so much, Professor. Sorry for taking.
Thank you. Appreciate that. I think referral systems are always challenging. You know, how do you balance rational to rationing? So let's stop there. I want to hand over to our chair today, Dr. Abdullah from Sudan, executive board member. A closing comment on behalf of Spark. I don't know if anybody from Spark would like to make a closing comment. Dara, feel free to do that. Dr. Abdullah? Okay, Dara, would you like to make a closing remark from?
Thanks, Shabir. And it's really great to see the interaction here. I think we're excited to see, first of all, the interest, particularly with those who are working at the PHC level, to begin to think more about increased financing and, of course, better purchasing for healthcare at that level. We look forward to more engagements and seeing how we can unpack some of these things. and probably spend some more time looking at what are the solutions, what are the kind of policy reforms, and how can we implement those in our different countries. Yeah. Thank you so much. It's been a very great time here. Yep.
No, thank you very much. I think Dr. Abdullah is available, so let him close as well, and then we can shut shop.
Yes, at the end of this very, very valuable workshop, I would like to deliver a great deal of thanks for all participants. When I say all, I mean all the 100 participants. Our participants reach 100% during this workshop, and I'm very fond of that. So great deal of thanks for you all, for your contribution, your thoughts, your questions, and your comments. Thanks for making this workshop successful by the enthusiasm that you expressed. And great deal of thanks also for our partnership, the partner of the Spark. I would like to thank Dr. Nkechi for her valuable presentation and for her valuable contribution to the success of this workshop. And also to our panelists, Dr. Stella and Anna. And a lot of thanks for the our moderator for the discussion, Professor Shabir. Your contribution was highly appreciated, and thank you all. And I think that all the contributions that you made during this workshop will be like a roadmap for us in AfroPHC. We will organize all these contributions for making like roadmap for the healthcare financing in Africa. And this indeed will not be the end, but we promise to have other events that shape the healthcare financing in Africa, and we all together work towards achieving the universal health coverage in Africa, our beloved continent. Thank you very much.
Thank you all very well. Dr. Abdullah said, bye-bye, everyone. Thank you. Enjoy weekend.